Hi, I'm Theresa Alt. I'm with Democratic Socialists of America. So you might think I'm going to talk about socialized medicine. Well, socialized medicine's okay. That's a system like the British system where doctors are on salary, where the government directly runs hospitals. Guess what? They get better health care statistics than the United States does. But I'm not going to talk about it because it's just not part of the political discourse, and we in Democratic Socialists of America are pragmatists. We look for what's possible. And what's just on the edge of the possible is single payer. That means all that the government takes over is insurance. The provision of health care remains private pretty much as it is now. You can have not-for-profit hospitals, you can have county hospitals, maybe you can have private hospitals. That's further down in the legislation somewhere, whether that's going to work that way. And certainly doctors will be in private practice, in group practice, much as they are now, much as they are in Canada. Canada, with that sort of a single-payer system, has health statistics very similar to those of the United Kingdom and better than the United States. It's the United States that pays twice as much as other countries and gets much worse results. So why does single payer work? It works most of all because you cut out the profits, and that's a big drain. You cut out a lot of the advertising, which is a big drain on what we pay for health care. And you cut out a lot of the duplicative bureaucracy. Because when you have 100, and there's far more than 100 different insurers, there's constantly looking, what system is this person, who is this person insured by? Does our office deal with that company? Does our office not deal with that company? What are the rules in that company? It forces the hospitals and the doctors to hire a lot of clerical staff to deal with those complications, and at the same time the insurance companies are hiring huge clerical staffs, you might say, to oppose the staffs of the doctors and hospitals. That strife between the insurers and the providers is total waste. And that's what gets cut out with single payer, and that's why single payer is the way that very clearly works best. Meanwhile, in Washington, the president, the Congress just can't bear to think about single payer. They're getting way too much money from the insurance companies, and so they are talking about some sort of a system that has several different, a pay-or-play system as it's called. That means several competing entities. It doesn't, it might get you to cover everybody in the gaps. It doesn't get you to reduced costs because you still have all these extra clerical workers. But there is talk about some sort of a wonderful compromise bill, and we don't quite know what it is yet. There are several bills floating around, and I'm just going to go through some of the things you have to look for to make your judgments about whatever comes up. If there is a compromise health care plan, be sure you must ask and make sure that it has an opt-out that lets states do their own single-payer plan, and that lets a state use the federal Medicare and Medicaid money when they do that single-payer plan. Then, some states won't have it, but some states will, like California probably, will start out experimenting with single-payer. We'll see that it can work. It'll spread. The other approach that's being talked about in Washington is what's called the public option. That is, that among all the different insurance companies on the menu, there is also going to be a public one, perhaps a lot like Medicare. And this will supposedly, depending on the plan, cover the people who are somehow left out otherwise. Again, you have to interrogate that public option carefully. A bad one is worse than nothing. A bad one is just a straw man made to fail, made to make public insurance look bad. If it is to be good, it must be government run, not contracted out to some profit-grubbing company. It must be set in such a way as to be affordable to working people so that it doesn't keep them from eating or force them into homelessness. If it forces people into homelessness, it'll just fail right from the beginning. The reimbursement rates to doctors have to be competitive. They have to be higher than what Medicare is now. Right now, providers are actually pulling away from accepting Medicare patients because of the limits on what Medicare will reimburse. And remember, their expenses include all those clerical expenses. That's why it's expensive. The system must be allowed to negotiate drug prices. It must allow anybody to enroll in it during enrollment periods. It must be allowed to compete for contracts from employers. In other words, employers should be allowed to cut a deal with the public entity. Then we have some real competition there. Patients on it, or subscribers, must be allowed to choose their own doctors. That's the choice that people want, not the choice of incomprehensible plans, whereas somebody else said you have to read a whole book, get a lawyer to read the book for you. And yes, there must be some sort of risk adjustments among the different competing companies. Otherwise, the private companies will cherry pick, as it's called, take all the well patients. They have all sorts of tricks for doing that, like setting their offices at the top of a long flight of stairs so that people who have problems don't even get there. And the public option, much as now, will be left with all the hard cases. So yeah, if it's done really, really well, that public option could be an option. Don't count on it. Ask all the questions. Thank you.